Dear colleagues, it is great honor for me to be invited to your Congress. I think the lecture I have prepared will be interesting for you. Prenatal diagnosis of genital anomalies in a male fetus includes evaluation of the scrotum, penis, and testes at different gestational ages. To date, there are no related guidelines or specific recommendations from scientific societies on this matter. The typical development of the male external genitalia requires the presence of a normal Y chromosome, an intact fetal hormonal axis, correct placentation that provides the necessary stimuli to operationalize the whole system. An aberration in any of these variables may cause genital anomalies. Presence of the SRI gene on the Y chromosome initiates male sex determination and testosterone production. Stimulation provided by the placenta of human chorionic gonadotropin causes the Leydig cells to produce androgen as early as the 7th week of gestation. During the initial stages of organogenesis, three basic structures are formed: biponational gonads, genital passages, indistinct external genitalia, including the phallus and genital folds. The influence of this androgen results in sexual differentiation, due to which the phallus elongates to become a penis. Genital folds fuse to form the scrotum. The bipotential gonads form the testicles. Placenta function continues until the 14th, 15th week of gestation, after which the production of testosterone becomes dependent on the stimulation of the fetal luteinizing hormone. External genitalia are completely formed by the 17th to 18th week and continues to grow regularly until birth of the fetus. It is important to know that by 25 weeks of gestation, only 7.7% of the testicles will have descended into the scrotum. By 27 weeks of gestation, only 12.5% of the testicles will have descent into the scrotum. By 34 weeks of gestation, 98% of the testicles will have descended into the scrotum. Questions. Why is the prenatal ultrasound examination of the reproductive system in a male fetus necessary? What are the possibilities of modern ultrasound equipment for the diagnosis of anomalies of the reproductive system in a male fetus? Aim: early detection of abnormalities related to the reproductive system in a male fetus. Syndromes related to the development of the male reproductive system. Syndrome of testicular degenesis, or Skakebeck hypothesis, which includes semiological disorders, carcinoma in situ transformation of gonocytes, cryptorchidism, hypospadias. In the figure, schematic presentation of the pathogenic relationships between the components and the clinical manifestation of testicular degenesis syndrome. In the next figure, illustration of the relationship between the relative frequency of various symptoms of the testicular degenesis syndrome. Note that while the overall incidence of TDS decreases, with the degree of severity, the relative incidence of testicular cancer increases. Cryptorchidism, or undescended testicles, involves the failure of the testes to descend permanently in their terminal scrotal position. The estimated incidence at birth is 2 to 3.4%, such as 75% of the cases are usually unilateral. Up to 1/3 of the cases resolve spontaneously during the first 3 months after birth. Evidence suggests that both the location and the time of cryptorchidism correlate with the loss of germ cells and Twilight cells. Paternity rates are similar in case of unilateral cryptorchidism, but significantly lower in case of bilateral cryptorchidism. Cryptorchidism increases the risk of testicular cancer by 3 to 8 times. Even though cryptorchidism is most commonly diagnosed in otherwise healthy children, it is important to remember that it is a component of almost 400 syndromes, many with important comorbidities. Other syndromes: Klinefelter syndrome, Swyer syndrome, androgen insensitivity syndrome. Is of interest the mild androgen insensitivity syndrome with normal external male genitalia. 5-alpha reductase deficiency syndrome, female phenotype or improperly viralized external genitalia along with the testicles. Disorders in the number of testicles, anorchia or vanishing testis syndrome or embryonic testicular regression. The absence of testis, 46XY karyotype, and an external male phenotype. Monorchidism, polyarchidism, testicular ectopy. Other testicular disorders: intrauterine testicular torsion, 34 to 38 weeks of gestation, testicular lithiasis, meconium periochitis. Disorders in the development of the scrotum: bifid scrotum, scrotoschisis, penoscrotal anomalies, scrotal transposition, additional scrotum, scrotal agenesis. Disorders in the development of the penis: micropenis, macropenis, maldevelopment, hypospadias or epispadias. Additional findings: scrotal masses can exhibit all types of morphologies, including solid appearance, cystic appearance, calcification, peristaltic movement. A color Doppler examination can show reduced, normal, or increased blood flow. Prenatal ultrasound of the testicles. The only ultrasound study on technical aspects is by FIGHT, which discuss correct visualization of the scrotum and testicles in late pregnancy. Ultrasound exploration is usually possible in 100% of the patients between 28 and 32 weeks of gestation, and the possibility gradually declines to 71.4% in the 40th week. Factors that prevent optimal visualization of the scrotum include decreased amniotic fluid and unfavorable fetal position. Testicular descent is the main qualitative change that can be assessed throughout pregnancy. There are several publications that have reviewed testicular descent using ultrasound, using magnetic resonance, anatomical studies. The descent is usually bilateral with less than 6% asymmetry, and the right testicle seems to be the first to complete the migration. Prenatal ultrasound of the scrotum. The studies measured the scrotum using different techniques. Acheron et al. Performed the measurement of the scrotum circumference from the outer edge. Pinet et al. Opted for a transverse measurement and the widest point and also from edge to edge. All of these studies have reported a high correlation between anatomical measurements and gestational age. Prenatal ultrasound of the penis. In comparison to postnatal measurement, there is no consensus regarding the techniques, measurement, and values for prenatal measurement. Types of measurements. Classic measurement from the tip of the glans to the edge of the scrotum, also called the outer penile length. From the tip of the glans to the pubic symphysis. From the tip of the glans to the proximal edge of the corpus cavernosum. From the tip of the glans to the proximal edge of the corpus spongiosum. Additional measurements. Measuring the width of the penis. A good correlation with the length of the penis. Measurement in additional curvature and hypospadias. Dynamic use of ultrasound and Doppler mount to locate the stream of urine at the tip of the penis. Drawbacks on the measurement of the outer penile length. OPL is a partial measurement of the penis which does not correspond to the postnatal measurement that accounts for the whole length. OPL can also lead to error in situations in which the fetal penis is normal in length but hidden by prepubic tissues, such as buried penis or penis palmatis, and in the presence of hernias or hydrocele. Drawbacks in the measurement by other methods. Difficulties in correctly identifying the set structures, corpora cavernosa and corpus spongiosum. Other confining factors that affect the measurement, such as the filling state of the bladder, fetal erections, ration, and ethic characteristics. What are the criteria according to which ultrasound examination of the reproductive system is recommended in pregnant women with a male fetus? Pregnant women with high and very high risk, age less 16 and more than 37 years, cardiovascular diseases, hypertension by a mild degree, use of alcohol, cigarettes, and drugs, endocrine and metabolic diseases, serious other concomitant diseases, wall-one placenta, placenta previa, icrita, percrita, placental insufficiency, intrauterine fetal retardation, oligohydramnios, suspicion of fetal abnormality. Pregnant women after in vitro procedures. Pregnant women who are diagnosed in 32 gestation week, maldevelopment or unclear ultrasound finding, defects of the scrotum, absence of one or two testicles in scrotum, unclear ultrasound characteristic in the testicles, reduced size of the testicles, presence of micro or macro penis. Pregnant women with an established tumor mass, solid or cystic, of the male fetus in the area of the external genital. We offer a twofold ultrasound examination during pregnancy, 16 to 18 gestational age after the initial testosterone peak, as we reverse attention to the size of the penis, the diameter of the scrotum, the correct formation of the scrotum, the anogenital distance. 28 to 34 gestational age, when it is expected that in 98% of cases, he has completed the descent of the testicles and there is still good visibility of the external genitalia, paying attention to the presence of two well-formed testicles feature of the scrotum, the size of the testicle, the length or width of the penis, the diameter of the scrotum is correct shaping, and the presence of additional findings such as solid masses, cystic formation, or intestinal contents. Scrotal in a fetus of 17 weeks of gestation. Diameter of the scrotal in fetus in the 17th week of gestation. Length of penis in a fetus of the 17th week of gestation. Length of penis in a 30th week of gestation. Diameter of the scrotum in fetus in the 30 weeks of gestation. Length of penis in the 30 weeks of gestation. Testicular size in the 32 weeks of gestation. This is contact for a question. Thank you for your attention.